Our next speaker is Maureen Baldwin. That was a wonderful segue, that last question, because she's going to talk to us about the role of inflammation in heavy menstrual bleeding. Maureen is assistant professor of obstetrics and gynecology at Oregon Health and Science University. She's a Werher Grant recipient. She's working on biomarkers in the cervix for diagnostic strategies in early pregnancy, but she's known to us for her advocacy for young women with bleeding disorders and her collaborations with her hematology colleagues.
Thank you. I'm so pleased to be here, and thank you for inviting me to speak. I think it was because I mentioned something about matrix metalloproteinases, and then I became the expert on that, or something like that. But I think if you try to make me the expert on that, I might escape through this little escape portal back here. I am just so excited to talk to you a little bit about menstrual physiology. And I hope that doesn't put you to sleep at this time of day. But just a broad overview, some thoughts that came up as I was putting together this talk, looking down more at a really focal level. And actually, Gao's talk was a really great segue because there are just so many interacting mediators for this process. But when we try to put it back into the person, to the patient that we see, it comes up with a lot of questions about how it's actually working. So I take a lot of menstrual histories in my work and really detailed down to like what happens at night, what happened when you first got up in the morning. And it's just so perplexing to me that even in the moderately heavy non-bleeding disorder patient who's normally cycling, that she will have just, there'll be vast differences in how that bleeding is exhibited. Some patients will have moderately heavy constant bleeding. Some patients will have flooding or gooshing, as one of my patients likes to call it, and then nothing for a while. Why does it come and go for some people? Why does it stay heavy and constant for others? What is actually happening at the endometrium physiologically that is doing that? These are my disclosures. So I'm going to try to review the overview of menstrual phase. What is the onset? What are the steps in the cascade, which is an inflammatory cascade? What's actually happening at the endometrium? And then I'm going to be doing this talking about normal cycling women, because actually the data that we have for heavy menstrual bleeding is pretty sparse. We have a little bit of data about how some endometrium is different in heavy menstrual bleeders, so I'll focus on that. Really nothing about bleeding disorder patients. And then we'll talk a little bit about some evidence that we have for effectiveness of various interventions targeting this pathway. So now that it's in the 70s in Portland, Oregon, my kids think it's summer, and they put on their swimsuits and go shivering out to the backyard and turn on the sprinkler all the time. And then I go and turn it down, and then they turn it on, and I turn it off, and they turn it on again. And because the sprinkler sat out for half of the fall, it's kind of rusty, and it doesn't really turn off all the way, and I'm always slogging through the puddle to get to the faucet. I really kind of think about this sprinkler on-off issue as the endometrium bleeding during menses. So when is it really on? When is it really off? And this is really the process of inflammation. When we think about inflammation, it's edema, it's leakiness, it's hyperemia, it's recruitment of cells, of mediators, and it's also repair, and it's also self-limited. So it's not just the beginning of this phase, it's also the end of the phase, the turning off part that's really interesting to me, where I think a lot of questions still are here. All I want for Mother's Day is for someone to turn off the sprinkler by themselves. Thinking back to the menstrual phase and the menstrual cycle. So this is secretory phase. Mid-secretory phase is where the body is ready to accept an implanted embryo, and it's ready because humans undergo a natural, spontaneous process of decidualization of the endometrium. Once the endometrium is decidualized, if an embryo doesn't implant, it's really good for nothing. It needs to go away and it needs to get better again. And actually humans and non-human primates are the only species that do this, that undergo spontaneous decidualization. Why do we do that? I don't really know, but it's why we have to menstruate, so that we can clean it up, freshen it up, and get new good structure to the endometrial lining that is ready for an embryo. And so in this late secretory phase, there's a response mechanism that results in collapse of this thickened, decidualized extracellular matrix, and then the menses, which in this picture doesn't really show it, but it's kind of like from here to here, blood. And then that is driven by this drop in progesterone. That's the trigger for the initiation of this event. And then there's sloughing, there's vasoconstriction here, and then the proliferative phase is the repair phase. And that's where the bleeding happens. This is a tightly regulated inflammatory cascade that leads to the breakdown of the endometrial complex. So the first signal is progesterone withdrawal. So the absence of binding to local progesterone receptors in the epithelial cells and stroma leads to a release of cytokines and chemokines, which recruit migratory cells. This initial part is actually reversible. Some really nice studies done in rhesus macaques where they primed their endometrium, they ovariectomize them, which is the term for oophorectomy in animal research. They gave them estrogen implants and then progesterone implants and primed their endometrium, and then removed the progesterone implant and then replaced it at different timings to see like what was dependent on the progesterone or not. And they saw that if they replaced the progesterone capsule by 36 hours, that they could reverse the next phase of this process. So up until then, the migratory cells coming in is reversible if you give back progesterone. But after that point, when they bring in the mast cells and they activate them, and they lead to the proteases, that activates the matrix metalloproteinase activity, which leads to degradation of the extracellular matrix, collapse of the matrix, and then the sloughing, apoptosis, and degeneration, which is menses. And this is a lot of crosstalk in here, and this is my bird's eye view of the whole scenario. During this time, there's an abundance of inflammatory cells, not just during the early secretory phase, getting potentially the host defenses ready for embryo implantation, but also potentially getting ready for decidualization. There's also a huge influx right at the end of the secretory phase, preceding the menstrual phase. I actually think this graph doesn't really do it justice because they really come in about right here, right before menses starts. And this is macrophages, neutrophils, uterine natural killer cells, eosinophils, T lymphocytes. So the various sizes on this graph depict the abundance. So, but in the rest of the menstrual cycle, they're not there. So, so in this story of the patient who's having all these infections premenstrually, this is potentially what's mediating that process. And there's extensive remodeling that's going on too of the vasculature, and this is an area I know much less about, but essentially the spiral arteries are remodeling significantly during secretory phase, and they're widening, they're branching. There's a lot of angiogenesis going on here, and you can imagine that if someone has a lot of really large vessels, maybe they're going to bleed more, and so. So we know that the menstrual phase is really characterized by vasoconstriction. One of the ways we know this is a really creepy study where they took macaque endometrium and they explanted it into the anterior chamber of the and then they observed vasoconstriction. And the way that it's described in the study is waves of vasoconstriction, which to me sounds sort of like this kind of very controlled, but sort of like repressed and then recontrolled sort of process. And that is really interesting to me. It makes me think about that sprinkler a little bit more. So there's vasoconstriction. Hopefully, maybe some people don't have it working very well. Maybe there's a difference of balance in heavy bleeders. We don't really know. And then undergoes healing and growth, and then vessel transformation to these large vessels again. So there's a balance of vasodilation and vasoconstriction going on throughout the cycle, and probably from moment to moment as well. And I'm just going to review this two-phase theory of the onset of menstruation because it gives us an idea for where to target interventions. So progesterone declines. That is the top of the story here. That is the really important part because actually this is our best target. That results in increases in COX-2 and in chemokine release, as we showed, and then prostaglandin synthesis. And that leads to this influx of leukocytes in recruitment phase. And this is the phase that up until now is reversible, up to 36 hours. But then further, it results in MMP activation, tissue sloughing, and the lytic phase. And it's much more complex than that. That was pretty simplified. But thinking back to the COX pathway and to the arachidonic acid metabolism pathway, we have up here at the top the COX enzyme sort of driving this whole process of prostaglandin synthesis. And prostaglandins are really important in not just PMS and all the menstrual symptoms that come along with the inflammation and edema, like cramping and bloating and GI upset, but also these tissue effects. And they can be classified into categories that are more vasoconstrictive or vasodilatory. And in abundance in endometrium are prostaglandin E2 and PGF2 alpha. And these have been studied pretty extensively. But one confusing thing is that these prostaglandins, vasodilatory, vasoconstrictive, are really not present in different amounts in women with heavy bleeding versus not in serum. And there have been some suggestions, though, in endometrium at carefully controlled timings that there was an increased ratio of PGE2 to PGF2 alpha. So PGE2 at this point seems like one of the best targets to look at to assess whether there may be dysfunctional regulation in women with heavy bleeding, to my mind. And that's ignoring all the other very important mediators here that are also prostaglandins. So at the top of this pathway is really targeting the COX enzymes, and we know that there's the constitutive COX-1 expression, which is pretty ubiquitous, very important in platelet aggregation. And then COX-2 enzymes are a little bit more of a mediator here in the process of this onset of this pathway. So when we look toward thinking about these targets, there have been a variety of Cochrane reviews looking at interventions. Actually, going back and looking at these Cochrane reviews, the majority of them are about management of irregularities with use of hormonal contraceptives. That's where a lot of the work has been done because there's just so much more research in that area. Looking back to try to find just treatments for heavy menstrual bleeding is really fairly sparse, actually. And then a lot of the studies in those reviews are mostly hormonal management studies and lots of comparative studies using different hormone regimens. And relatively few studies looking at non-steroidal anti-inflammatory drugs or this other stromal target that I want to talk about, the matrix metalloproteinase inhibitors. So regardless, all these studies look at very specific outcomes, and one of the more specific outcomes that has kind of started to go by the wayside, actually, is looking at measured menstrual blood loss. And I want to just remind everybody that this is such a useful tool in the studies that assess menstrual blood loss because it's very accurate, even though it's expensive and time-consuming for patients. So if you haven't had the pleasure of hearing about this process, I'm just going to give you a general overview, which is that you purchase a package from a company like this for your research study. Patients receive a keg, this red-lidded, very sealable thing that they keep in their bathroom. They are issued specific menstrual products, which are on the market also, but they're ones that can be digested by the stomacher that has to digest down all of the menstrual products to get to the blood to perform the alkaline hemotin assays. So patients collect all of these specific blood menstrual products, but they also have to make sure they capture all the wiping and all of the clots onto these products and into these plastic baggies as well. And they're issued little carry cases and all sorts of things to make sure this works well. And then they bring them into the collection site and send them into the company. We get a report back that says measured menstrual blood loss using this method. Which is pretty accurate. And it's considered that 80 milliliters is the upper limit of heavy menstrual bleeding because that's the 90th percentile for heavy bleeding. Actually, in the 60 milliliters is where we start to see iron deficiency. So 80 mils might even be a little too high sometimes. Most studies have to use at least a few run-in cycles to establish whether the patient is a heavy menstrual bleeder because you know, sometimes you might have a heavy cycle and then it might be light the next one, and we want to make sure we're really capturing over time. And this, you know, the corollary is the PBAC, which is a very well-validated and very effective tool that is much less expensive to use. It requires probably also some standardization of the menstrual products the patient is using because it's usually a proportion of the product that they're charting, and also needs to make sure that there's some compliance evaluation in terms of how frequently and in real time they're actually filling out their PBAC cards. But if that's undertaken, then this can be a useful tool as well. So going back to the 70s, when we started looking into options for NSAID management for heavy menstrual bleeding, there were a few sentinel studies back then that looked at mefenamic acid, which we don't have on the market in the US to my knowledge. Somebody correct me if I'm wrong. And they used this on several patients using the measured menstrual blood loss assessment. And this graph depicts one particular patient who had a copper IUD and had 160 mils of bleeding per episode over each cycle. That was her average for several cycles. They treated her with mefenamic acid for 2 cycles and then went back to no treatment and then treated for 2 cycles. You can see here this dramatic decline in her bleeding, and this was very reassuring. In addition, they also published data on several more subjects as well, but wanted to highlight that it could be effective treatment for the bleeding associated with copper IUDs. And so on from there, there are other studies demonstrating the effectiveness of NSAIDs in comparison even to progestin methods. So this is an RCT of mefenamic acid versus cyclic progestogen, northisterone, in a small number of subjects. Subjects had 2 cycles for their baseline, and they had a pretty high amount of bleeding from 100 to 250 mils per episode in both groups, and then demonstrated approximately 20% decline in their bleeding over 2 treatment cycles. And this is useful, it's reassuring. It's also kind of what we see in practice, that patients' bleeding will decrease by about 20%. But what I find really interesting about these graphs is that it seems like about half the patients really responded and about half didn't really. And same with the northisterone as well. So maybe there's a lot of heterogeneity in the patient population. Maybe larger sample sizes would be really useful for looking at NSAIDs. And there are not a lot of studies with larger sample sizes, honestly. So there's even room here to just show the effectiveness of NSAIDs head to head. And then here's another early study comparing levonorgestrel 20 IUS to tranexamic acid or flurbiprofen, another non-selective NSAID. And subjects were randomized to either the IUD or to tranexamic flurbiprofen arms. And if they were, and they all had baseline evaluation and for two control cycles. And then if they had the tranexamic acid or the flurbiprofen, then they were in a crossover trial for 2 treatment cycles for each. So these are the same subjects who had N of 15, who had mean menstrual blood loss measured of 295 compared to the LNG 20. N of 16, and they're in the 200 range, so still pretty good. And this is actually the proportion of decrease that we see today with the levonorgestrel intrauterine systems, or tranexamic acid, approximately 44%, or NSAIDs, approximately 20%. And this is what I quote my patients, that they could see a decline of up to 95%. So which NSAID should we use? Celecoxib is certainly a great option, especially for patients with bleeding disorders or concerned about platelet function. It's well tolerated, it's safe. Sometimes patients, I feel, have a reticence to use a medication with a prescription. They may be more likely to go to something over the counter. And I tend to use naproxen for many of my patients. It's also been shown to be very effective head-to-head with Celebrex. Flurbiprofen, haven't heard of that before on the market either, but these are the dosing that were used in the various studies. There's not a lot of comparative data between the different classes. Moving on then to the interventions for MMPs, doxycycline is a potent MMP inhibitor at sub-antimicrobial doses. MMPs are zinc-dependent proteolytic enzymes. They're basically what's responsible for the degradation of that endometrial complex and the sudden collapse that occurs along with menses. They're gelatinases. They lead to increased vessel fragility. Interestingly, MMP2 and MMP9 are increased with use of cyclic oral hormonal contraceptives and also with progestogens. And so we, at our institution, looked at using doxycycline for treatment of breakthrough bleeding with continuous oral pills. And one of my colleagues, Bliss Kanishiro, who's now at University of Hawaii, she designed a study recruiting women to have serial endometrial biopsies after being on continuous pills, and she randomized them to doxycycline or no doxycycline. And unfortunately, she was not able to continue the enrollment for the entire study to be able to report out on it, because it turns out people don't really like getting serial endometrial biopsies. At baseline, the MMP9 activity is here, and then with cyclic COC, it would be about here, and then continuous, so no hormone-free interval without doxy, and continuous up to here with doxy. So there was a suggestion of some impact, and they had shorter time to amenorrhea than, which was not significant given the small sample size. Doxycycline hasn't been studied in normal cycling women, and it hasn't been studied in heavy menstrual bleeding women. So this is another potential target area that could be a really easy study to do, aside from the multiple endometrial biopsies. So just to review that, that progesterone decline is at the top of this, and so continuing progestin without an abrupt drop in progestin is probably the best target that we have. And then COX inhibitors are a helpful target next, and then MMP activation inhibitors are a potential future option to consider. As I was putting together this talk, one of my colleagues came over and said, "You know what works for inflammation for me?" She said, "I've been taking turmeric because it's the only thing that's helped my foot not hurt and I can go running again. So you should totally talk about turmeric." And so I said, well, I'm going to look and see if that's actually been researched at all. So it turns out there is actually a little bit of data, so I thought I'd present it. that curcumin is able to abrogate IL-1 beta-mediated IL-6 signaling in human fibroblasts. So they did this in vitro study of taking human fibroblasts and put them with IL-1 beta, see a significant expression of IL-6, and then IL-1 beta with the curcumin or curcumin alone abrogated that. They didn't show a change in the receptor activity. They showed a change similarly in GP130, which is an important signaling molecule for IL-6, so I thought that was interesting. So we wanted to look at other herbal medicines just to make sure we didn't leave anybody out. And there's a systematic review of these 3 reasonable studies looking at Persian gulnar flower versus tranexamic acid, showed a 50% reduction in the PBAC score, similar to tranexamic acid. Myrtle fruit syrup versus placebo syrup, slightly shorter cycle, fewer pads. Didn't have any comparative data for the placebo outcomes. Ginger capsules versus placebo decreased the PBAC by half and to a level that would be potentially great and acceptable for some people. So there's some promise there for ginger. In our neck of the woods, this pharmacy created a vitamin called Slow Flow, which you can buy for $18.50. And a lot of my patients are on this, so it's no laughing matter. So what's in it? You can't read this very well, but mostly it's vitamin A, C, and K, and there is a warning on it for vitamin K. And then there's some ginger, but there's no turmeric. So a lot of my patients say that this tablet helps at first and then not after that. And I think that's really interesting. So we can at least go to the New York Times recipes and make something with turmeric in it to help our inflammation. I think what I'm left with after looking through all this data is that I think that there are really some unknown areas here that deserve a little more investigation. Being someone who uses a lot of levonorgestrel intrauterine systems, I think I'm probably going to stick with that one for most of my patients. But I think that knowing the relative effectiveness of these various interventions and using them to create our inquiry into why this is happening is a really interesting thing to think about. So, thank you for your attention.
Thank you for a really great talk. So, I mean, obviously, a lot of us here are treating bleeding disorder women, and
Yeah.
are any of these studies done in bleeding with a known women with a known bleeding disorder?
I don't think so. I don't know how well people were screening for bleeding disorders in some of these early studies, but no, I don't think so.
I'm also wondering, because the one graph you showed where it clearly
Studies of levonorgestrel IUD in bleeders, women with underlying bleeding
Yeah,
disorders.
yeah.
We have that.
Some IUD studies, but
Right,
yeah,
sure,
small.
sure. Not, I mean,
Yeah.
specifically with NSAIDs, I think this is really interesting because we always tell them don't take it.
Yes.
Don't take turmeric, no ginger, none of that. So, but maybe there's something to it. But I also wonder, in the graph that you showed, that's really, really interesting, where it seemed like it was 50% of women really had a reduction and the other 50% didn't.
Mm-hmm.
What are those two populations? Do you know any more about that?
No, we don't know any more
But
about
that would
that.
be interesting to look
Yeah,
at.
yeah,
Yeah.
And you know what we tell our patients, especially like our von Willebrand's type 1s who don't have a lot of other bleeding symptoms, is you can try NSAIDs at the full dose, and if it increases your bleeding, then we're not going to do it anymore. But if it doesn't, or if it helps, then we can do it as long as you're not exposed to other bleeding potential.
Thank you.
Mm-hmm.
Peter Quitas, University of Rochester, very nice talk. As far as the inflammatory component, do you regard that then as part of as a necessary, in a way, component of menses? If not, is there any way in the future that you could categorize or classify certain patients as being with increased inflammation, and perhaps those are the ones where you may think of an old medication you mentioned, perhaps danazol with steroid-like, properties.
Yeah. I think that I previously might have said who needs the inflammation, but I think it's actually probably most important for repair and remodeling. And if that angiogenesis is dysfunctional in the proliferative phase, maybe that's what makes everything worse. So I think we have to think about that repair mechanism as well. And I think some of, like danazol has been studied head-to-head with some of these and didn't show much improvement, but it is a potential option still for some patients.
Hi, I'm Janice Bacon. I'm a general OBGYN who does pediatric and adolescent gynecology. And I just had a couple odds and ends things to say, but I really appreciated your perspective from looking at menses from this inflammatory directive, because we tend to look at it so much clinically. So mefenamic acid is available as a brand name Ponstil. Okay. The problem is nobody uses it because you can hardly get the insurance companies to cover it. You have to do prior authorizations, and our Medicaid in South Carolina won't cover it for just about any reason. Number two, the comment from our first speaker that was also excellent about the gonococcal infections. Please don't forget to check these people for gonococcal or chlamydial infections, because that will work against everything else. Number three, doxycycline and the zinc is so interesting because there's a lot of comparisons between GYN and dental care, and they use zinc modification as part of their treatment for inflammatory conditions in the mouth. The contraceptive article used 40 milligrams of doxycycline, which they had compounded for the study, and the lowest dose that's commercially available is 50 milligrams as far as I'm aware. But my last question to you really was, when we think of using doxycycline for some of its anti-inflammatory properties, also in some skin conditions like hidradenitis, we use clindamycin and partly for its anti-inflammatory properties. So did you see anything about clindamycin, for example?
I didn't see anything about, thank you for your comments, Janice. I didn't see anything about clindamycin, and I don't know if it would potentially be effective. I think it's worth thinking about, really. And I'll just make one comment. Thinking about the mefenamic acid, I just hadn't heard of it used before. I did note that a number of studies report that it has some PGE2 receptor activity as well. And I don't actually know if our other non-selective NSAIDs have that same activity. So it would be useful to know if there's a difference between that one. Could help with funding for it.
Nathan Kabrinsky from University of North Dakota. First, in Europe, there is a medication that is widely used for treatment of decreased blood loss with adenotonsillectomy and menorrhagia. And it's called ethamsalate or dicyanine. Mm-hmm. And it just never caught on here. In fact, it's never been licensed here or sold here. I did 2 years ago, several studies with it in blood loss in tonsillectomy. And I also looked, there's a long, long time ago, there's this thing called the bleeding time. And anyway, looked at ethamsalate in bleeding disorders and found, for example, that ethamsalate was synergistic with desmopressin and that it shortened the bleeding time in von Willebrand disease and in platelet function defects. In other words, non-specific glue. It's been thought to play a role in prostaglandin mediated or modulation that's not Cox determined. That's the theory. Comment about the zinc. Zinc, is it good or bad? If you take doxy, presumably it's binding to the zinc and depleting it, and we know that depletion of zinc can cause a condition called acrodermatitis enteropathica, a zinc-deficient condition where you get sloughing of your gut and sloughing of skin in your hands and feet, and hair loss. I don't know if that's very good.
Thank you for your comments, everyone. Yeah, there was a comparative study of ethamsalate versus one of the NSAIDs, I can't remember if it was celecoxib, but, it didn't show as much promise, but I'd have to look back to talk to you about it later. Thank you.
So thank you very, very much. Oh, Janice, did you have one more
One
question?
more,
or
this is and what I meant to ask earlier. So I was wondering if anybody had looked at collecting menstrual blood using a menstrual cup, like a Diva cup, and if that would have any reasonable correlation. I know it might be hard to find a vessel to store it in, but to me that seems like it could be used from beginning to end and would be relatively easy measure.
I'm not aware of any studies that use it, but that is a good idea. I do know that there is a smart pad technology in the works for doing some assessments of hemostatic factors, but I don't know a lot about it, sorry.
Well, thank you very much, Maureen. That was very, very helpful. And so now the next time the reviewer writes, well, you haven't discussed inflammation and the role of heavy menstrual bleeding, I'll be able to say, well, here's what we know. So thank you.